All right. So now we are live. Shall we start, ma'am?
Yes, sir.
All right. So hi, good evening, everyone.
Good
Good
evening,
evening,
sir.
sir.
So I'm
Good
glad to
evening.
see you all. And before we start with anything, let me tell you something very, very special. That this session that we are going to have today, it's one of its kind of a session which probably has never been taken like this. And this is a clinical case presentation series where we are going to have all our volunteer students who want to present a clinical case based on any of your patient, any of your topic that you might have read in your medicine, surgery, OBGY, orthopedics, pediatrics, or any of the subject that you are studying right now. So see, this is a special series where we are trying to give you the clinical insights. And this is especially for all our FMG students, right? So there is always a lack that we feel that in probably in most of the colleges in India, you have lot many patients. And in abroad countries, because of various cultural reasons or various other limitations, we have little lack of clinical exposures. So now this is one of that clinical case presentation series where our own students, they are going to prepare a case, they are going to present the case, and we are going to have a series of this so that we all read the topic at once, and we all get so confident with the topic that whether it is your university exam, whether it is your FMG exam, NEET exam, any of your exam, you are very, very clear with all the clinical parameters of that particular case. Right. So this is our little initiative where we are very, very glad that so many of you have joined us. Some of you are on the Zoom, some of you are on the YouTube. And I must congratulate Ayan. So Ayan is a sixth year student at Fargana Institute of Medical Science at Uzbekistan. And he was the first one who took the initiative that, yes, I'll be presenting the first case. And trust me, guys, it's not easy to be the first one, right? So the first one who has taken the lead and he's presenting with a case of pain abdomen. And let's see where the pain abdomen leads us to. What is this patient suffering from, how he can reach to the diagnosis, how he examined the patient. So that is what we have for the day, right? Ma'am, anything you would like to say to all
Yeah.
of the
So,
students?
good evening, Bachu. So, this is, like Sir said, this is the first of its kind of its initiative, which has not only been taken in Fargana by the SSS, but this is first initiative which has ever been taken in the FMG segment. And this case presentation, see, Bachu, when you want to become a doctor, right, it is not just theoretical knowledge which matters, it is also the practical knowledge, the way, the analysis, how to come to a diagnosis, how will the patient present to you. All that makes you a doctor, right? Theoretical knowledge, you are always studying, your bookish knowledge is there with you. But with these clinical presentations, you will learn how to apply your bookish knowledge into a clinical knowledge. And these days, when we are saying that questions which are coming are clinical, this case presentation, these case presentations will help you in acquiring that clinical acumen, which you need not only to solve your MCQs, but to become a good clinician as well, right? So through these case presentations, during this case presentations, what I want from you people is just to be very, very observant what is being told by the patient and how we are coming to a diagnosis. Be very open, ask questions. Whatever doubts you have, it's always better that you come up with those doubts, you ask those doubts, because this is something which is going, your curiosity is something which is going to now take you ahead. So these case presentations, which have been started by SSS, this is for the FMG students, by the FMG students, and from the students. So lots and lots of luck to all of you. And thank you so much, sir, for taking this initiative. And thank you, Ayan, for being the first one to present a case on pain and abdomen. So happy
You're
learning to
welcome,
all
ma'am.
of you.
So, Bachcho, those who are with us in this Zoom, now let's wait for Ayan to present his case. Let's see how his patient came, and let's see how his patient of pain abdomen turns up into something very interesting. And let's try to learn the topic as a whole, right? So, yeah, somebody's asking me
Yes, sir.
only the FMGs. Yeah, Ayan, yeah.
Yes, sir. I'll try to share the screen.
Yeah. So Sapna, please, Ayan ko writes though, make him the co-host so that he can share the screen.
Sir, Ayan is already host.
Acha, Ayan, try to share your screen.
Is it visible?
No.
Not yet, Ayan.
Sir, one second, I'll do it.
No problem. Take your time. So, bacho, by the time Ayan will start a case, I'll tell you what exactly a case presentation is. Case presentation simply means that when a patient comes to you, right, how as a physician we are supposed to evaluate a patient, right? Whatever complaint, whatever problems he's telling us, we are supposed to have the elaborations of that, and then step by step we go for the examination of the patient, right? That is the meaning of a clinical case presentation. So you all know when you do your MBBS, when you complete your MBBS, first of all, we all become a physician, isn't it? And the clinical evaluation of the patient is the most important thing, right? History taking is an art. Clinical examination, you all have to be wonderful at that, right? So if you just, evaluate the patient very, very nicely, most of the time, the 80% job, the 90% of the job can be done by history and clinical examination. Investigations will have to play some less role if your clinics are very, very good, right? So now today you're going to see that when Ayan will present his case, then how the patient has come to you, what all his complaints were, and why a patient's complaint has been taken up in a particular manner. And then we are going to learn the elaborations of that particular case, right? So let's have a little learning of what exactly a clinical case presentation is. And let's see how his patient turns up into some, definitive kind of differential diagnosis or provisional diagnosis. And then how we proceed with the final investigations and the treatment plan, if we can understand that as well, right? So Ayan is having some network connection on his side. Yeah. Ayan, it is very much visible. All right. So as you all can
Sir,
see,
now is
Ayan
it
shared
visible?
his screen. Yes, yes, it is visible, Ayan. You can start. So he's presenting a case of patient who is coming to you with pain abdomen, abdominal distension, and let's see how it comes.
Okay, sir. So, so my friends, I am Ayan
Right. So
from sixth year.
Ayan, over to you, and you can start presenting.
Yes, my case is case of abdomen distension. Yeah. So patient details: name Mr. Ramesh K, age 54 years, sex male, occupation auto rickshaw driver, address Chennai, date of admission 1/12/2025, informant patient himself.
Now,
Chief complaints.
Ayan, please hold on to the first slide, please. Please hold
Okay,
hold
sir.
on to the first slide. Now, see,
Yes,
bacho,
sir.
here in this case, if you all can make out, yeah. So why exactly do we have a need of patient's details? Let's understand this as well, right? In the patient detail, the patient name has been given to you, age has been given to you, occupation has been given to you, and informant has been given to you. Now, understand when you tell about the patient details, right? So, Ayan, would you like to mention that what is the importance of this occupation here, and what is the importance of this? Who is the informant here?
Sir, if they belong to by occupation, we can understand their social economic status, and if it is some are they poor, so like they can get TB, like
Mhm.
so we can get to know the few
Right.
diseases which are due to their occupation.
Very, very good. So see, I'll tell everyone. See, there are two important things here in this slide, patient detail. Number one, the occupation. Like Ayan said, it's very right that first of all, we come to know about the socioeconomic status. Second one is a driver. then we can link up the profession to multiple things, right? And the informant is the patient himself. Like if I say very common thing in a rickshaw driver, or at this particular age group, it may be alcohol, okay, which is common in this socioeconomic status, or maybe we are just guessing it. Patient is the informant himself. That means the patient is well oriented to time, place, and person. Patient is not under any intoxication, so patient is able to tell all his complaint, right? So these are two most important things from the very first slide. Ayan, we can proceed, please.
Yes, sir. So the chief complaints: abdominal swelling for 2 months, bilateral leg swelling for 1 month, decreased appetite for 1 month, fatigue for 1 month.
All right. So now here, everyone, pay attention to this. When you look at the chief complaints, there are 2 to 3 important things that everybody must be, focusing upon. Number one, all the complaints are written in a chronological order, right? So always remember, I will never mention in my history that my patient is having decreased appetite for 1 month, but abdominal complaint is for 2 months, right? Always in a chronological order. It has to make a sense so that you know which complaint came first and which trouble came last. Now, in the very first complaint, Ayan has mentioned that it is an abdominal swelling, right? See, will the patient be complaining of swelling? When you say swelling, that means it has to be a localized thing. So, Ayan, is your patient having a localized kind of some lump or some swelling on the abdomen? Is it?
No, no, sir. Not
No,
localized.
right? So, in the chief
Overall.
complaints, patient, it is not localized, right? So, abdominal distension can be your complaint. Fullness feeling in the abdomen can be a complaint. But when you are saying that abdominal swelling, then it most commonly, it most often presents or points towards a localized kind of problem, right? So wording should not be a abdominal swelling. Wording either has to be fullness of the abdomen, distension of the abdomen, right? So swelling should not be a complaint here. Okay.
Okay, sir.
All right. So that is very good. So this is one message we all got, that swelling should be localized. It has to be a localized complaint, but abdominal distension or fullness should be the right word. Very good, Ayan. We can proceed. Next slide, please.
Okay, sir. So this is an image of the abdomen distension.
Very good. So guys, this is how the patient is presenting to you. The fullness around the abdomen, the distension of the abdomen, right? This is a clinical presentation that patient is coming to Ayan with, right? Perfect, Ayan.
So past medical history: diagnosed with chronic alcohol consumption disorder for 20 years, no known history of diabetes, hypertension, tuberculosis, CKD or heart disease, no previous hospitalizations, no history of jaundice in the past.
All right. So I'm very sure each one of you can make out that past medical history is not very significant. Now, one common mistake that we often do and is present here is diagnosed with chronic alcohol consumption for 20 years. Now, see, this is the history of the patient himself, right? So any alcohol consumption, any smoking, any of his habit has to be a personal history. It is not a medical history, right? It becomes a medical history when alcohol consumption has led to some other problem for which he must have required some hospitalization, right? So this first line should not, the first statement here should not be coming in the past medical history. It should be going to the personal history of the patient, right? Now, before the past medical history, one thing which we missed here is, Ayan, number one is the chief complaint, right? After the chief complaint, you are supposed to put the elaborations of the chief complaint. Then only we go to the past medical history, personal history, family history, like that. So do you have the elaborations of your patient?
No, sir. I think I started with past medical history itself.
Okay. So in the further slides, do you have the elaborations of your
Yeah.
complaints, chief complaints?
Yes,
So,
sir. I have elaboration of the complaints.
right. So first, we always elaborate the present illness, chief complaints and present illness. Right. So can we go to the present illness, please?
Sir, drug history.
No. Just hold on. First, present the present history, the history of present illness. Okay, just check. That's okay. That's okay. Take your time. No?
Sir, I think I've missed.
No problem. Okay. So what you do, you just allow me a moment to share my screen.
Yes, sir.
Right.
Stop share, right?
Yeah, you stop share and
Mm-hmm.
I'll share now. So I'll tell the present history. So me and Ayan, we have discussed the case. And if you all can see my screen, now this is the history of present illness, right? Now see, I'll elaborate what Ayan has presented. I'll Okay. So this is the history of present illness. Ayan told you the complaints of the patient, right? So patient was apparently well 3 months ago when he noticed gradual abdominal fullness. Initially, it was less and gradually it was progressive, right? Patient also observed that abdominal girth was increased and gradually become very, very significant, and is all the clothes they become tight. Whether it was his shirt or his trouser, they became tight. Gradually, he started complaining of early satiety, mild breathlessness on exertion. So initially, breathlessness was not on the sitting posture, on the resting posture. It was on exertion, right? And during this initial period, there was no abdominal pain, there was no vomiting, there was no hematemesis, melena, or any kind of yellowish discoloration, right? Gradually, then he developed pedal edema, which was pitting in nature. It started from ankle and now gradually progressing towards the legs. Okay, during this time, there was no fever, no altered sensorium, there was no bleeding, any complaint which was showing any bleeding. Okay, urine output was gradually reduced, but yes, it was not dysuria and bowel habits were normal. Now, you all can easily just analyze here what all are the important things in the present history, in the history of present illness. See, initially, the problem started with the abdominal distension, right? And because of this abdominal distension, patient started having breathlessness on exertion. So there was no exertion while the patient was in the resting phase. Number one. Number two, it says there was no history of vomiting, hematemesis, melena, or jaundice. Now, what does it tell you? See, abdominal distension can have multiple causes, and we'll come on to that. But when you look at this particular age group, where Ayan has already mentioned that he has been a case of chronic alcohol consumption for last 20 years. So one of the commonest problem after the alcohol consumption we can think about is some liver disorder, right? Maybe portal hypertension, maybe, cirrhosis of liver, maybe some ascites, something related to that. So we know alcohol can do that. So if there is a portal hypertension, involvement of liver, involvement of spleen, we know that there can be a upper GI bleed, there can be a bleeding per rectal, it can be a, vomiting which can happen. So melena or liver failure can create jaundice. So initially we are having no positive history in that favor. So we are having only one or two important points: gradual distension, breathlessness on exertion, and pedal edema. Now, pedal edema also can have multiple causes. And patient is not telling you any kind of facial puffiness. They're only complaining of pedal edema, which started from ankle. And you know that ankle edema, right? It can be a part of maybe the cardiac pathology or sarca. So we have multiple causes. So from present illness, we have these three things. Okay. So somebody was mentioning that the history of present illness is missing. So this is the history of present illness, which Ayan missed. That's absolutely okay. So we are just trying our best. So first, always remember, the first has to be the presenting complaint, what the patient presented to you. Number two, elaborations of the presenting complaint, right? That is called as history of present illness. So how it all started. All right. Now, Ayan, now you over to you again. Now, after the present history, you will tell me the past history. You can share your screen again. Yeah.
Yes, sir.
Now we'll start with the past history.
Mm. Past medical history, diagnosed with chronic alcohol consumption disorder by 20 years, no known history of diabetes, hypertension, tuberculosis, CKD, or heart disease. No previous hospitalizations, no history of jaundice in the past.
Perfect. So now, as discussed, Ayan, your first statement will go to his personal history.
Yes, sir.
Okay. All right. Perfect. Can we go further?
Yes, sir. Drug history, not on regular medications, occasionally takes over-the-counter analgesics for headaches, no known drug allergies.
All right.
Social history, alcohol consumes 180 ml spirits daily for greater than 20 years. Smoking, smokes 10 to 12 cigarettes per day for 25 years. Diet, mixed diet, poor nutritional intake, decreased appetite recently. Occupation, long working hours, irregular meals. Socioeconomic status, lower middle class.
All right. So basically, your history says that he is a chronic alcohol consumer as well as chronic smoker, right? So 10 to 12 cigarettes per day for 25 years.
Yes,
It's
sir.
quite a long duration, right? And looking at the history of smoking, we should also have some suspicion of something going wrong with the respiratory system. Okay. And alcohol consumption for more than 20 years, there might be a probability of the liver system getting involved, the abdominal system getting involved. Let's see. And diet, you are saying decrease appetite recently. Okay. Let's see
Yes.
what it is up to. Okay, fine.
Family history, no family history of liver disease, chronic alcoholism, or malignancies. No history of similar complaints in family members.
All right.
Okay, sir. So now we'll proceed to general examination. General appearance, ill-looking, drowsy but oriented, cooperative, build, moderately built, poorly nourished. Vitals, temperature 98.6 degree Fahrenheit, pulse 98 per minute, regular, respiratory rate 20 per minute, blood pressure 110 by 70 mmHg, SpO2 96% on room air.
All right. So nothing significant you have got in general examination in the vitals. But when you look
No,
at
sir.
a general build of the patient, he's looking drowsy, right? So why do you think, what was the reason that your patient was looking drowsy?
Sir, like I think maybe because of like some involvement to the CNS due to the like liver getting damaged.
Okay.
So
See,
maybe like
when you're saying,
maybe he's drunk.
oh, if he's drunk, then he's a very, very good person who is very balanced even with his drunk state. See, why? Go to your previous slide, what you have written. Go to the previous slide. When you're taking his previous one, the personal history where you've written, no? Now here, look at this one. You are saying he's having a poor nutritional intake. This one only. He's having a poor nutritional intake and decreased appetite, right? He's a
Yes,
smoker
sir.
and he's an alcohol consumer as well as long working hour and irregular meal, right? Can't the tiredness be the reason for his fatigue look or
Yes, sir.
drowsy look?
Long working hours can be.
Yeah. Long working hours. Now, when you say somebody is saying hepatic encephalopathy, so patient won't be cooperative. Patient won't be listening to you, right? So in general state of the patient, when you're talking about the general examination of the patient, we always write down that patient is well oriented, right? Ill looking, drowsy, you have written. So if the patient is responding to you, you have written already cooperative. So poorly nourished, that can be very well a reason for his drowsy look and ill looking look, right? So if you suspect something big, it has to be
Yes, sir.
hypoglycemia. Okay, so if it is hypoglycemia, then why it should be oriented one? In hypoglycemia, will the patient be oriented one? Once the patient starts going into hypoglycemia, he starts losing his orientations, right? So that is a simple thing. Ammonium toxicity, hepatic encephalopathy, beta, not like this randomly. We don't just put anything anywhere. Okay, so vitals are normal. If there are toxicity signs, the vitals will not be normal. Okay, so respiratory rate is something which I can say it is going little on the higher side, like 20 per minute. It is little on the higher side. Normal respiratory rate, we always say it is somewhere between 14 to 16, 17 per minute, right? So everything is fine. It is all because of his poor nutrition. All right, let's go to the
Yes,
next
sir.
one.
General signs,
All right.
pallor present,
Okay.
icterus mild,
Mm-hmm.
cyanosis absent, clubbing absent,
Mm-hmm.
lymphadenopathy absent, pedal
Mm-hmm.
edema, pitting type present up to knees,
Okay.
signs of chronic liver disease, spider angiomas present, gynecomastia present, palmar erythema present.
All right. So basically, see, Ayan, seems like you have already made your diagnosis that it is chronic liver disease, right? So in the general
Yes,
examination
sir.
only you have made your diagnosis, right? So we never do like that. In a general examination, we are only supposed to present whatever finding is present in your patient. So what you're saying, pallor is present, icterus is present, cyanosis absent, clubbing absent, lymphadenopathy absent, and the signs of chronic liver disease, right? We always say in a sequence after lymphadenopathy, you must have put lymphadenopathy in upper part only, which you have done. Wherever you are, palmar edema is present. Now, palmar edema has to be okay. It is on my side. Network issue is on my side. Am I audible to you?
Sir, some network issue.
Am I audible now?
Yeah, sir, now you're audible.
All right. So sorry for the disturbance. I was just saying that when you do the general examination of the patient, you always have to do that in the head to toe sequence, right? You will never put it like this, that lymphadenopathy done, pedal edema present, and then signs of chronic liver disease. Now, looking at this, it seems like that you have already made your diagnosis. So in general examination, we never made a diagnosis that it is a sign of chronic liver disease. How do you know? There might be some other issue as well, right? Second, we always put things in a sequence. So before pedal edema, you must have put over here that in the patient, I can see gynecomastia. We can see some spider angiomas on the abdomen or wherever you are able to see them, and some palmar erythema is present. And the last line has to be pedal edema. All right. So always it goes head
Yes,
to
sir.
toe. So we start from head, eyes, and then gradually down. So this line will not be right here to say that it is a sign of chronic liver disease. You can't make a diagnosis here.
Okay, sir.
All right. Let's go further.
Now we'll proceed with the systemic examination. Cardiovascular system.
Mhm.
On inspection, no precordial
Mhm.
bulge, scars, or visible pulsations. On
Mhm.
palpation, apex beat not displaced. Auscultation
Okay.
S1, S2 normal, no murmurs. So
All right.
cardiac system is normal.
Okay, fine. Tell me,
Mm-hmm. Hello,
in the any significance of this?
sir. I'm not able to listen to you.
Okay, I'm saying in the cardiovascular system, you are saying that on palpation, apex beat is anything significant which you can make out?
Sir, there is no cardiomegaly, so like it's not displaced.
All right. So remember this line will come back to this line, okay? Remember this line, this finding will come back to this. Once you present your case, we'll come back to this line, okay? Just continue.
Okay, sir.
I'm just writing it out so that I remember it. I'm writing it down. All right, please carry on.
Respiratory system inspection, slightly decreased basal chest movements, percussion,
Mhm.
stony dull note over lower lung zones, suggestive of pleural effusion, auscultation, reduced breath sound at bases.
All right. So you are saying that in respiratory system, you are able to get dull note, and you are saying that it is most likely a pleural effusion. Okay. So are you saying it is pleural effusion on both the sides or single side?
Right side, sir. Right.
Only on the right side, you are saying.
Yeah.
But if it is on the right side only, then why on auscultation there is reduced breath sound at basis? Is it also on the right side or both
Like it's
the sides?
slowly progressing from the right side to the left side.
No, no, it will never progress from right to left side, right? Progression means when it occurs at a localized area and then it involves diffusely any region,
Yes, sir.
right? So first thing is in the respiratory system, if you want to say that it is a particular side which is involved, you must mention the side, whether it is right side or left side or whatever. Number one. Number two, when you are saying in the percussion that it is a stony dull, then you are already telling you that it is having some pleural effusion. So it has to be bilateral or unilateral, that you have to again confirm. Okay, and wherever on whichever side you have said respiratory system auscultation is reduced, again you will have to just confirm bilateral or unilateral, which is not mentioned over here. Okay, so in the respiratory system, some correction is required. All right, we go next.
Okay, sir. Next one.
All right.
Gastrointestinal system. On inspection, distended abdomen, flanks full, everted umbilicus, visible dilated veins, caput medusae, no scars.
All right, so you are saying now in GI system, you can see the abdomen which is distended and everted umbilicus. What is the importance, relevance of this everted umbilicus?
Sir, because the peritoneum is filled with the like ascitic fluid, it's pushing the umbilicus outside, so it's everted.
All right, fine. And what is the relevance of this flanks are full?
Flanks are full, sir. On supine position, if we make the patient lay, the ascitic fluid will go on the dependent sides, so the flanks will get full on
So
the
how much
right
fluid,
and
if
left side.
somebody's flanks are full, if somebody's
Yes,
flanks
sir.
are full, how much fluid do you think is
Hmm.
already there in the abdomen?
I think, sir, 500
It
ml
is,
should be there.
yes, it has to be more than 500 ml. Perfect.
500 ml.
Fine. So this is fine. Okay. So one respiratory side is wrong and one cardiac finding we have to come back. So I'm writing it down. Okay, fine. Please proceed.
Okay, sir. Palpation, abdomen is soft, liver mildly enlarged, firm, spleen not palpable, no localized tenderness, shifting dullness present, fluid thrill present, hernial orifices normal. Yes, sir.
All right. What is the purpose of this
Percussion,
shifting dullness here? What does it signify? Shifting dullness?
shifting dullness. So, sir, in the center of the abdomen, we can appreciate tympanic note, but as we move downwards, it changes to dull note because the fluid goes to the dependent parts of the body due to gravity, and then we can appreciate the shift of dullness, sir.
Very good. Perfect. So with the movement of the patient, the
Yes,
dullness and resonance, they will keep on
changing, sir. Like,
occurring again and again. Very good. Wonderful. Fine. Right? ठीक है.
thank you, sir.
Ayan, carry on, please.
Yes, sir. On percussion, central tympani with flank fullness, shifting dullness positive, auscultation bowel sounds present, reduced in frequency.
But tell me something, Ayan. In
Yes, sir.
percussion, you are saying that it is
Mm-hmm.
central tympanic node with flank which are full,
Yes, sir.
right? Central tympanic node with flank which are dull. So that means the whole
Mm-hmm.
abdomen is full of fluid.
Yeah, sir. Almost, sir. Uh, like it's going to the dependent parts yet. Full abdomen, I don't think it's full yet, sir.
But you have written central tympanic node. If it is central,
So,
your
so
dullness. Yeah. So some little mismatch. That is okay. Now see, when you have that much of fluid, will the
yes,
bowel
sir.
sound be present?
No, sir. I think it should be
Okay,
absent,
I'll take your point.
but it's reduced in frequency, sir. It's there, but
Maybe
it's
I'm agreeing. Okay, I'll take that point. I'll take your point. Benefit of doubt. We'll take that point. Not a problem. Right. So, okay, fine. Let's go. And I'll come back to your slides again. Fluid will be collected in the horseshoe manner. Okay, fine. ठीक है, ठीक
yes,
है.
sir.
Go to the next one.
Okay, sir.
Mhm.
Central nervous system, conscious, oriented to time, place, person, mild hysterexis, suggestive of early hepatic encephalopathy, no focal neurological deficits, and genitourinary system, no suprapubic tenderness, no normal external genitalia.
All right.
Yes, sir. Local examination, inspection, gross abdominal distension, flanks full, umbilicus stressed and everted, visible superficial abdominal veins, no localized swelling or redness.
All right. So now you're writing here in the local examination, you're giving that there is a gross abdominal distension, flanks are full, umbilicals is stretched and everted. But now you're writing no localized swelling or redness, right? So now that means
Yes,
you're
sir.
predicting your first complaint itself, abdominal swelling, right? So it
Yes,
should not
sir.
be a swelling, it should be abdominal distension or fullness in the abdomen. That is the feeling the patient is having.
Yes, sir.
All right,
Gross
fine.
abdominal distension. Yes, sir.
Gross abdominal distension. Fine. Okay, go to the next one. Now look at this image, and look at this image, and everyone
Yes,
else,
sir.
please look at this image, the previous one.
Mhm.
See, Ayan has commented upon in CVS a point that apex is not shifted, right? That is what you mentioned.
Yes,
Now,
sir.
that is the relevance of epsilon. Go to the previous image.
This image, sir.
Go to the previous image, previous image. Yeah, this one. Now look at this, everyone, please. When you look at this image, Ayan has commented upon a
This
point.
one, sir.
No, same image, patient image.
Okay, sir.
The one you were showing,
This
no?
one.
Patient standing in the next
Standing, sir.
inspection.
Okay.
Inspection, yeah. Inspection
Yes,
finding.
sir.
Yeah, same patient, yeah. Now, Ayan has commented upon a point in the cardiovascular system. Apex is not shifted, right? So now understand, when you are suspecting a patient to have gross ascites, right? What can happen? The apex can be moved, apex can be shifted. So when in the cardiovascular system, you're commenting upon the apex, then you're telling that even if you're suspecting some ascites, right? Then even it is not that gross that which is able to shift your apex. Okay, so that is a relevance. When you say no shift in the apex, that is a relevance here. All right, I hope everyone got that.
Yes, sir.
Yeah, is it fine?
Yes.
All right,
Yes, sir.
go ahead with the next one.
Palpation, temperature normal, no localized tenderness, hepatomegaly present, splenomegaly absent, fluid thrill positive. This is the fluid thrill.
Palpation, that local. See, you don't write temperature.
Hmm.
On palpation,
Okay. Hmm.
you write down, it is local temperature. No local rise, right? It doesn't have to be temperature. No localized tenderness, which is fine. Hepatomegaly present. Okay. Splenomegaly is not yet there. And fluid thrill is there. Okay, fine. What do you think is fluid thrill?
Sir, on flicking the finger on from one side, we will feel the palpation of the fluid on the other side of the flank,
Okay.
and then this is the fluid thrill.
So do you think that fluid thrill will be present in every case?
No, sir. Like it should be having around 1.5 liter to 2 liters of ascitic fluid, sir.
So ideally, it is more than 2 liters of fluid when you can see only the fluid thrill, right? And when
Yes,
you're
sir.
feeling the fluid thrill, you must, keep one of the examiner person should keep the hand, the patient's hand or the person's hand should be kept in the middle of abdomen to give some pressure. You hit from one side and you feel the movement of the fluid on the other side. That is what you call fluid thrill.
Yes, sir.
All right. Fine. Please go to the next one.
Percussion, dullness in flanks, central tympani, shifting dullness clearly present, auscultation, bowel sounds diminished, special test, puddle sign, and assessment for hernias negative.
Okay, so you're saying it is puddle sign. So you have another word here. Bowel sounds are diminished, shifting dullness clearly present, central tympani, dullness in the flank. All right. What is that puddle sign?
Sir, on laying the patient on all fours, the ascitic fluid will come on the center near the umbilicus. Even if it's around 150 ml, we can appreciate on percussing the umbilicus area. This is the puddle sign because it gets accumulated like a water in puddles.
Now, please tell me one thing here. In the previous slides, you have told that there is a central tympani, then there is a fluid thrill, right? When the fluid thrill you told me is seen in the abdomen when the fluid is more than 2 liters. Am I right? Fluid is more than 2 liters, right? So
Yes,
when you
sir.
have fluid already 2 liters present, which is giving you fluid thrill,
Yes, sir.
do you really need to do the puddle sign?
No, no need, sir. Directly we can elicit
Yeah. Okay, so
fluid thrill.
puddle sign even will not be required here. Right? So if you have fluid which is less than usually 120 or 150 ml basically, for that much of fluid, we go for puddle sign.
Yes, sir.
All right? Okay, fine. Please proceed.
Yes, sir. This is the image of tympani, transition point and dullness. This is shifting dullness.
Okay.
Yes, sir. Done with
Okay.
the presentation, sir.
All right. So what do you think, Ayan? You have not shown us the picture of your patient having those nevus or the abdominal changes or engorged veins. You mentioned about them, but you have not put the pictures of them. You have not got the clicks of them.
Yeah, sir. I couldn't get.
Okay, fine. No problem. No problem. All right. So if you have a fluid thrill, still no need to do shifting dullness too. Absolutely, beta, you are right. See, please understand, everybody who is watching us live right now, you have to understand a few things. Number one, these case presentations are a way to understand the topic as a whole. See, somebody just mentioned that if somebody is coming with abdominal fullness, distension, then go for ultrasound. We are not radiologists, okay? We are physicians first. And to earn that radiology degree, you have to pass this exam, no? NEET, PG, INI set exam. So radiology banne ke baad to you can do anything you want. Absolutely your choice, right? But right now we are trying to figure out if a patient is coming to you with a particular complaint, then how we proceed with this general examination, systemic examination. Okay. So this is our aim. Our aim is not to prove that we know everything and we can go. MRI can tell me everything. Ultrasound can tell me everything, right? Seating can tell me everything. Then what is the point of having a clinical knowledge? So right now, these series will, pave us our way, or they will give us some insight how to crack the clinical presentation of a patient. Okay. That is the whole idea, right? Fine. Ayan, your case presentation broadly told me. So can you just summarize your patient's presentation until the examination? All the positive things. Can you just summarize them?
Sir, my patient has gross abdominal distension, which is progressive in nature, and he has
Okay.
pitting edema, which is up to the knee. Uh, he has fatigue, and he has been a chronic alcoholic since 20 years, and he smokes 20 packs per day for about 20 years itself, and
Mhm.
and he belongs to a lower socioeconomic status, and he is an auto rickshaw driver. It belongs to low socioeconomic status. He has long working hours, and he doesn't have a
Mhm.
proper time for his meals, and
Mhm.
and like he has fatigue, and he has dyspnea
Right.
because of the
Okay.
abdominal distension and the fluid which is going through the pores of diaphragm, and Yes, sir. These are the major complaints which the patient has, and we have elicited central tympani and shifting dullness on the patient and fluid thrill, by which we could understand that there is some amount of
Okay.
ascitic fluid in the patient.
Mm-hmm. Okay.
Yes,
So if Ayana summarized it very, very well, and for the understanding of and for the understanding of everyone, I'll just summarize it. So we have a adult patient, 52 years of age, chronic smoker, chronic alcoholic for last 20 years, presenting to you with progressive abdominal distension, progressive pedal edema, which is pitting in nature, with some dyspnea on exertion. On examination, the positive findings are pallor present, icterus present, bilateral pitting edema present, right? On systemic examination, the breath sounds, they are decreased probably on right side or left side or both the sides. The breath sounds were not palpable and there is dull note on the respiratory examination. Abdominal examination, we saw that the patient is having complete abdominal distension and there is some fluid fill which is present, which usually comes with having more than 2 inches on the abdomen also were mentioned. Okay, so these are the positive points. Have I missed anything or all the positive points covered?
yes, sir. Covered.
All right. So looking at the broad scenario based on your clinical evaluation, based on the history you have presented, based on the findings you have seen, what do you think is your diagnosis? What do you say? How will you
Sir,
mention this patient?
my provisional diagnosis is ascites secondary to chronic liver disease,
Okay.
which is, yes, sir, alcoholic liver disease.
All right.
This is my
So
provisional diagnosis.
if you say, let me just write it down. Okay, let me just write it down. So I have two questions for you.
Yes,
Right?
sir.
You are saying your patient is having ascites secondary to liver disease. Okay.
Yes, sir.
Okay. Now tell me please that your patient is having
Mhm.
ascites secondary to chronic liver disease. I'm just sharing something with you. I have a question for you.
Yes,
So
sir.
just a moment. And now see this. Can you see my screen as well? Is that visible to you?
Yes, sir.
Is that visible to everyone?
Yes, sir,
Yes,
now we
sir.
can see.
Yeah. So now I want to know from you, Ayan, ascites, you are saying it is secondary to
Yes,
chronic
sir.
liver disease, which probably you are saying alcohol related. I agree. Now you tell me,
Yes,
is
sir.
your patient having a chronic liver disease with or without portal
Mm-hmm.
hypertension? Is it with portal hypertension or without portal hypertension?
Sir, for that I will have to order a test. Like I will have to do
Oh, come
ascitic
on.
fluid
Wait. Portal hypertension. Why do you need to go for a investigation? Anything are you
No, sir,
getting in the health?
like with caput medusae can be because of like portal hypertension.
I don't know. You tell me. You mentioned a few things which are positive, which are negative.
Yes, sir. Spider angiomas, uh, caput medusae,
Mm-hmm.
and palmar erythema, gynecomastia uh, makes me want to say talk about liver disease, which is alcoholic.
No, I understood your point. My question is simple. Is your patient having some features of portal hypertension or no?
Yes, sir. My patient has.
It has portal hypertension.
Yes, sir.
What are the points in favor which tells you it is with portal hypertension?
Sir, caput medusae, abdominal veins which are distended, and
Very good.
gynecomastia, spider nevi, and palmar erythema.
Very good. Perfect.
Yes, sir.
Perfect. Perfect. I agree. These are the points in favor of your portal hypertension. But is there anything which is negative also in not in favor of portal hypertension, which should have been ideally positive?
Mm, ideally be positive. Sir, splenomegaly should have been there, I think.
Okay. It could have been there. Fine. Anything else which tells you it is which is negative, which is against portal hypertension in your history of
Sir,
mention?
no bleeding or stool, no
Very
bleeding in
good.
stool.
No bleeding,
Mm,
right? No hematomesis,
no
no
bleeding,
melena,
madam.
nothing is there.
Yes,
Very good.
sir.
So clinically, the patient is symptom free from the signs of portal hypertension, right? But signs are visible, symptoms are not there right now. Okay, so this is one thing. So your patient is having ascites, which I agree, secondary to the chronic liver disease. Okay, with portal hypertension. Now tell me, is this chronic liver disease, is this ascites, is associated with a compensated liver disease or a decompensated one?
Sir, decompensated?
Why do you say it is decompensated?
Mm.
Why do you say it is
Sir,
decompensated?
because
You can
it's
share your screen.
moving to sir, because it's moving
Mhm.
towards cirrhosis.
It is moving towards cirrhosis.
Yes, sir. So,
Okay. Fine, I'll take that point. Anything else? Any other point in favor? Anybody else want to contribute?
sir, massive ascites because of cirrhosis is making me say about
Nahi,
decompensation.
that. All right, fine. So decompensation is happening because if decompensation wouldn't have been, like compensation would have been happening, no portal hypertension wouldn't have developed, right? If the liver would have been working fine, why would there be a, pressure on the portal system where the signs are present, but symptoms right now you told me is not there in the patient, which is little unusual to happen, right? When the abdominal changes have happened, when the veins are shining on the abdomen, the ascites is too high, that your fluid thrill is present, that means usually portal hypertension will be showing you some features, which right now you told me it is not there, right? Little uncommon to see, uncommon to be there, but yes, maybe we can agree on that. Fine. Now tell me, what will be your, this is your provisional diagnosis you have made. Can you mention some differentials also for this? Any differential that you would like to mention?
Yes, sir. For cirrhosis, heart failure, pancreatic ascites,
Which
tuberculosis.
kind of, wait, which kind of heart failure?
Sir, right heart failure.
Right-sided,
Right
left-sided,
side. Right.
right
Right
side.
heart
What do
failure.
you call that? What do you
Right
call
heart
that?
failure. Core pulmonale.
What do you call that? Right-sided.
Right
Okay,
heart failure.
simplifying
Core
this. What do you,
pulmonale, sir.
what is
Core, core pulmonale.
called pulmonale? See, pulmonale. What is cardiac ascites?
Cardiac ascites. Sir, because of right heart failure, the blood will go back to the portal system and increase the portal pressure, causing the capillary to increase permeability and leak the fluid out. This is
Wonderful.
because of. Yes, sir.
So good. Wonderful. This is too good. Right? So absolutely you are right. That is what you call cardiac ascites. All right. Now tell me, if you have, like somebody said, किसी ने mention किया that we want to go for ultrasound. Let me see कौन था. Somebody said we want to go for ultrasound. Yes, definitely you can go for ultrasound. Not a problem at all. Yeah. So now tell me, how will you proceed forward with your patient? You are saying it is a fluid thrill, right? So what you are going to do with this patient now? How will you manage this case? What all investigations, 1, 2, 3, 4, 5 you can do?
Sir, first I'll order ultrasound and check if there is fluid, and then
Directly
I'll take.
ultrasound. No basic investigations, directly ultrasound.
Sir, yeah, basic investigations. I'll order CBC, CBC
Okay.
cytology. I'll do culture. Then CBC, LFT, RFT. I'll do that and check the liver function, kidney function, and
Okay, tell
that
me
I'll like.
very basic things. Ayan, very basic things. In the CBC,
Mhm.
how do you think the status of hemoglobin will be?
Sir, it will be less because the patient was like belong to low socioeconomic, might not be having proper
No,
meals.
no. You only mentioned in your history the patient is having pallor,
Yes, sir. Anemic patient was.
anemic.
Yes,
You already mentioned no, patient is anemic, so
sir.
hemoglobin has to be low. Now,
Yes,
if
sir.
which kind of cell in CBC do you think will be raised if it is infective?
Sir, leukocytes will be raised. Mm,
Which
neutrophils.
one indicates infection now? The neutrophils. Okay, neutrophils. Fine.
Neutrophils.
All right.
Yes,
What
sir.
else you would like to have? One is what you said is the basic blood evaluation. Agreed. What else?
Sir, ascitic fluid tap I would like to do. And
Ascitic fluid tap you would like to do. Okay, fine. What do you want to check in
yes,
that? All right. Chalo,
sir.
tell me one thing. Tell me
Mm-hmm.
one thing. You'll get the this fluid out. You'll get for the
Mm.
fluid out for evaluation. What kind of
Yes, sir.
fluid do you expect here it to be?
Sir, in this I will like want to be it clear, straw colored or light green because I'm suspecting cirrhosis.
Oh, straw colored you are saying.
Clear, sir. I will suspect clear, straw colored.
Either it has to be clear or it has to be straw colored, no? Will it be a okay? How many types of fluid you know which are coming out like this? What kind of
Sir,
fluid?
blood. It can be bloody if there is some malignancy.
No, no, no. How do you define these fluids which are coming up as ascitic fluid or any swelling? We have two kind of fluids. Okay?
Mm-hmm.
We
Yes,
aspirate and do blood.
yes,
We have either a
sir.
transudative fluid or we have
Transudative and
a
exudative.
perfect. What is the difference in the two?
Exudative.
You are suspecting
Sir,
exudative fluid.
transudative is caused by like if there is portal hypertension.
Take your time. Take your time.
Sir,
Easy.
if the cause is
Yeah. What kind of
sir,
fluid you will
if the
expect
cause
in
is
your
due
patient?
to portal hypertension, in my patient I would expect transudative fluid because the cause was portal hypertension
Hmm.
and in portal hypertension we get transudative and in non-portal hypertensive cause we get this thing exudative, sir.
No, not like that. Transudative are those fluids or
Hmm.
those swellings which occur because of increase in the hydrostatic fluid pressure or the
Yes, sir.
decrease in the
Portal.
oncotic pressure, right?
Yes,
So
sir.
that is what portal hypertension is. Okay, variability in the
Hmm.
oncotic pressure or the hydrostatic pressure. So that will lead to the seepage of the fluid, and that is what you call transudative fluid. Exudative fluid
Hmm.
is when somebody is throwing the fluid out. Why should somebody exudate is what? Something which is coming out of something that is an exudate. Why a fluid will be coming out? It all happens because of some sort of infection, some sort of
Hmm.
inflammation, some sort of malignancy. Whenever there is an increase in the vascular permeability, right? So
Hmm.
that is what you call an exudative. And that is why the transudative fluids, as they occur because of the difference in the pressure, that is why they are clear, they are thin, and they usually don't clot on standing. But on the other side, the exudative ones are always infective ones, inflammatory ones, right? Increase in the vascular permeability. And that is why you said no, hemorrhagic, they can be turbid, they can be like purulent. So they usually are thicker one and they might, clot sometime, right? So tell me, there is something called as SAAG. Any idea about that? In this fluid, very, very important investigation always is the transudative versus exudative. Is something called as SAAG. Anything you know
Yes,
about
sir.
that?
Yes, sir. Serum albumin,
What is that?
ascitic albumin, gradient. So we will check albumin in serum and we will check albumin in ascites and we'll subtract that.
Hmm.
And if we get more than 1.1 gram per deciliter, it will be portal hypertensive cause.
Okay.
And if it's less than 1.1 gram per deciliter, it will be non-portal hypertensive cause.
Very good. Very, very good. So when
And
serum albumin minus ascitic fluid albumin,
yes,
right?
sir.
So what do you call this criteria? Any idea? There is a criteria which has been named to check all this. Do you know what is this SAG criteria is called as?
Sir, I don't know, sir, about this, but
No,
in
that is called as
pleural
lights
efficient,
criteria.
light criteria and pleural efficient.
Yeah, lights criteria is there in the pleural effusion. Same thing.
Hmm.
So in the abdomen, you just check for this gradient, right? And in the lights criteria, like you also already mentioned, no, in respiratory system, you also have some fluid. So you'll have to go for in the
Hmm.
fluid also, pleural fluid also. You only mentioned in your examination that respiratory bilateral, you said bilateral or single side, whatever side you are saying that there is a decrease in the
Hmm.
respiratory sounds, right? So if the
Hmm.
fluid is also there, then for the respiratory system, you'll have to go for lights criteria.
Yes, sir.
right? So okay, somebody has posted something in the, okay, my voice is still breaking, is it? Now, I think, okay, that was a message sent earlier. All right. That is one SAEG you said. All right. So one you said you will check for the transudator versus exudator. One is SAEG. Okay, now tell me, Ayan, if somebody is coming to you with ascites, how much fluid is it advisable to take out per day? If it is like you said, more than 2000 ml, 2 liters of fluid is already there. How much fluid is advisable to be taken out?
Sir, if it's without albumin, then up to 5 liter is safe. And if we give albumin, then we can take up to 10 to 15 liters in one sitting.
10 to 15 liters, you are saying?
With
Gadbad ho gaya yahan
albumin,
pe.
sir.
No. See, abdominal aspiration ideally should not be done for more than 700 to 800 ml. Some literature says up to 1 liter can be taken out in a day, right? You don't remove more than that. Okay. And always it has to be maximum 800 to 1000 ml, 1 liter. So 700, 800 ml is usually, no, it is not like, yeah. So it is 700 to 800 ml. Usually most of the literature says 500 to 700. Some say 700 to 800, maximum up to 1 liter, right? Never go beyond that. Okay, so that is a maximum aspirate you should be ideally taking out. Okay, what extra uh, advice you will give to your patient?
Sir, we will
My,
tell the patient to restrict salt and water.
Okay,
Yes, sir. We will advise the patient to restrict their salt and water. Salt below 2 grams per day, and water 1.5 to 2 liters maximum in a day, and abstain from any alcohol.
okay. And what else? One you said is salt restriction. One you said is fluid has to be taken out. Now, if fluid has to be taken out, if you are taking out fluid, there will be some lack of albumin also. No, why there is a pitting edema? Why there is
Yes,
pitting
sir.
edema? That is all
Sir,
happening
because
because
hypoalbuminemia.
hypoalbuminemia. Now you have to give albumin also. So when you are giving albumin to the patient, you have to be very, very, sure that you are giving salt-free albumins. Okay. So albumin has to be infused, alcohol has to be stopped, smoking has to be stopped, fluid has to be taken out, salt restriction has to be done, fluid restriction has to be done, water intake has to be minimized. These are few instructions that you are going to give to your patients. Now, what all categories of drugs can be used? Can you summarize the categories of drugs that can be used to take out the fluid?
Yes, sir. We can use diuretic spironolactone, which is aldosterone antagonist,
Okay.
and we
Okay.
can use furosemide, and
Okay.
amiloride we can use.
Okay, fine. As you
Then
as you
we should,
mentioned about furosemide,
yes, sir.
please tell me some complication which can be linked to it. Furosemide,
Sir, potassium can go along with that, and we can get hypokalemia,
right? And if hypokalemia happens, what can happen? What can be the further
arrhythmia,
complication?
arrhythmias.
That is with
Uh,
hyperkalemia. Arrhythmia with hyperkalemia.
sir,
Hyperkalemia can precipitate what? That is a very potential
hypokalemia.
complication. That is a very potential complication which may be linked to your liver failures. Think over it. Hyperkalemia causes arrhythmias, not hypokalemia. No,
Hmm.
hepatic coma, hepatic encephalopathy. You said your patient is having tremors. So patient is already having this tremors, right? Which may be linked to your hepatic encephalopathy. So if the patient goes into hypokalemia, it may be a potential reason for hepatic coma, right?
Okay, sir.
Now somebody has mentioned very, very rightly that patient is already having gynecomastia. Then should we be using this spironolactone? Yes, that is also very important catch point.
Hmm.
Right. So looking at the
Yeah,
patient's
then we'll.
parameter, you should be using whether you want to use furosemide. So furosemide will be a better drug, but then you have to keep a watch that you don't
Yes.
do over treatment. Over treatment with furosemide will lead to hypokalemias. All right, that is one. Now tell me about this. If the patient, what you are managing right now, Lactulose we can use. Yes, absolutely, you're right. Lactulose you can use. Absolutely, you're right. All right. Yes, due to loss of potassium and the hydrogen. Okay, fine. What you're saying is right. It makes sense. Okay, right. Now tell me, if the fluid, if the fluid you are taking out, you'll keep on taking out till the patient gets well, and we keep on giving the treatment plan. Now, anything else that can be done as an intervention in these kind of patients, other than taking out fluid?
Offer we can offer tips, which is
What is that?
that is transjugular intrahepatic portosystemic shunt will go from jugular vein, and we will make a shunt between hepatic vein and portal vein, so liver won't be involved.
They are
So liver
bypassing the
won't
liver,
be
basically.
bypass the liver and portal pressure will decrease.
Wonderful.
So ascites is one of them.
Very good. So, yeah, absolutely right. Lactulose, yes, you can use because you don't want the patient to have a constipation. Okay, because with constipation, again, see what happens is, what is the reason for aesthetics and the hepatic encephalopathy? The accumulation of the ammonia and the alike compounds, which will get onto the brain and will start the metabolic disturbances, right? That causes hepatic encephalopathy. So lactulose will not allow the constipation to happen. With constipation, things may deteriorate in the patients of hepatic encaph or the hepatic, like this coma. Okay, so tips advice, absolutely right, absolutely right. Okay, so this is now, yeah, iron supplement, depending upon if it is the that level of decrease in hemoglobin or no. Iron supplement is not advisable to every patient. Only if it is, indicated, if it is required, then only. All right. So now, Ayan, I think broadly you have covered almost everything. Okay. A few, I can say shortcomings which are there in the slides, and definitely that has to be there. We are doing something for the very first time, and I think for the very, very first time, it has been a tremendously, a wonderful effort from your side. You have taken a lot and lot of pain in
Thank you,
reading
sir.
about this thing, this topic. Okay. So, yeah, so it is hugely commendable, and I really appreciate the way you have presented it. Okay. And I really appreciate to take the lead and be the first one to present the first case. Right. So, Bacho, how was the case presentation? I just want to know right now itself. What do you say? How was the case presentation by Ayan?
Yes, sir. Wonderful, sir.
चलो साहिल, साहिल इज योर बेस्ट फ्रेंड है ना. साहिल वाज द फर्स्ट वन इंस्टेंटली टू टेल के यार ने अच्छा प्रेजेंट किया. बाकी सब सो
Yes, it was great.
गुड.
बढ़िया था.
So the first thing is to take the initiative. First thing is to start, and we are very happy that Ayan has taken the lead. And we just want to make, like, this way. This has been the first one. So in the first one, and please don't take any of these sessions as we want to, point out your mistakes, right? So we just want to go ahead in the same manner, having some more presentations the same way. We will do mistakes, we will learn, we will again do mistakes, we'll learn, we'll improvise, and that is what the aim is, right? So, ma'am, if you're here. ऑल राइट अयान, तो मुझे ये बताओ ऑनेस्टली, फॉर अंडरस्टैंडिंग ऑफ ऑल, कितना टाइम लगा इस टॉपिक के बारे में पढ़ने में? हाउ मच efforts you have to do, we have seen, but how much time did it take?
Sir, I read this topic from 2 books and few YouTube videos.
Very good. So now tell me something very honestly. Once you presented this case, will you ever forget any line about ascites?
No, sir. Now it will stick with me.
Yeah, right. So for the whole through your life, the topic is not going to anywhere. And when you'll be appearing for any of your exam, then for sure, this is going to help you out. And that was the whole purpose of, giving you this kind of case presentation. So whatever topic you are, presenting, you will be presenting. So all right. So the purpose was to give you a case presentation so that जो भी topic, whatever topic you feel you are weak in, उसको present करो. And when you will be able to present, then mistakes will come, errors will happen, we will improvise them together, and that is how we learn, right? So clinical case series, yes, this is going to happen, and we want to do it almost every Thursday. We have 3 more volunteers with us who have volunteered to present the case after Ayan. So case 2 is ready, case 3 is ready, case 4 is ready. Those who wish to volunteer can definitely put your names to us in your WhatsApp group, and we'll be definitely, doing some more sessions every Thursday, same 9 p.m. And, all the cases coming from medicine side, surgery side, OBGY side, maybe ortho side sometime, you'll get the cases so that you learn all the questions which are asked in your exam and all the patients that you're going to see. So let's not have that feel that we can't do the presentation, we don't see the patients. Let's not do that. Right, ma'am, if you're here?
That I'm here, and
Okay.
it was so amazing to see. Dr. Ayan, you were too good, right? I mean, for the first case presentation, it was one of its kind, and Dr. Ayan, it never appeared as if you are presenting the case for the first time. Ayan, genuinely, you have been
Thank you,
presenting the
ma'am.
case for the first time. Matlab, I'm actually surprised.
Yes, ma'am. First time.
So, how did you feel? Matlab, this all concept of preparing the case, preparing a PPT, and imagining the patient with sir sitting and
I'm
trying
reading
to.
from the 2 books. He has read from 2 books.
Yeah, so, and how was this experience? Because you have not done this, so I want to know from you, how was this experience for you?
Ma'am, I wanted to take this challenge because here we don't get to do all this like case presentation. So I wanted to be the part of this so I can explore my options and feel confident. Like
So,
I wanted
Ayan,
to
you have
communicate.
already, मतलब कितनी बार पढ़ा होगा ना,
I wanted to show that.
ascites, pain in abdomen. Now, how was it different this time? मतलब till now you had been reading books में topic पढ़ लिया एक ascites. Now when you had to present a case, how was it different?
Mhm. Now, ma'am, I'll be able to explain this to someone. Earlier, it was like only I know about this,
Huh.
True.
but now I can explain it to others about about ascites.
So that is what case presentation is all about, but where you are going to learn the topic in a very different way. You know, you are going to understand the topic from a very different perspective. Till now, you have been reading a topic from MCQ point of view, that this particular thing is asked in MCQ, this is asked in MCQ. But now you are learning and understanding that topic from clinical point of view, imagining that you are the treating doctor coming to a differential diagnosis, coming to a diagnosis. So that is what it's all about. And it will be very good to see if more of you volunteer. And every week, like sir said, we will be taking up case presentations, and even we will be growing with you. We will be improvising, you will be improvising, and that is how together we are going to go through this journey clinically together. So sir, it was very interesting.
Yes, ma'am, and all the applause for Ayan. He has taken a lot of efforts reading it from YouTube, reading it from the books, and now I'm very sure, like Ayan, Ayan will be the role model for everyone, and everyone will take up a case. And we have already 3 cases coming up. 3 volunteers have already. Naza, I can see, is here. She'll be presenting the case, and other 2 people are also there. So they will be presenting the case, and I'm very, very sure with each case we'll improve, we'll learn more, and it is going to be beneficial for all the attendees as well. Alina is already there. So it will be going to be like, it's going to be beneficial for all of us.
So, all
Right?
the students who have attended the case presentation today, I would just want a small thing from all of you. Number one, in your WhatsApp group, if you can write, how did you feel about the case presentation? And all those who are watching us on YouTube, if you want to be a part of the case presentation, in the comment section, write down what cases would you like us to present more. And if you want to be a part of the case presentation, just tag sir and put it in the comment section, and we will see to it that how we can have you for case presentation also.
All right, Bachcho, thank you so much. And Ayan, a big
Thank
thanks
you
to
so much,
you
sir, for
for
the
taking
guidance.
taking
Thank you,
the
ma'am.
lead. And now I'm very sure this will pave the way for a new beginning, a new initiative, a new program, a new series, and a new session. Right? So let's do something good for all of us. Let's keep learning together. and it's going to be very, very fruitful for all of us.
Thank you
All
so
right,
much,
so
sir. Thank you,
thank you,
Bachchan.
ma'am, and
Thank
thank
you,
you so
Ayan.
much, everyone. Thank you, Ayan. Thank
Thank
you,
you, sir.
Sapna.
Thank you, ma'am.
Thank you, sir. Thank you, ma'am.